All right, just letting participants come on in, but good morning or afternoon, depending on where part of the country or world you're in right now. This is Brandon Garrett, COO of the National Minority Quality Forum. As you know, if you're joining us today, you know that we typically have a Friday webinar. We just try to explain something in the healthcare space and policy. So I'm just going to go ahead and start the organization. Sorry for the little background noise here. I'm at Xavier University right now. I promised Keiko I was going to wear a Winston-Salem State sweatshirt today, but I forgot I had a meeting at Xavier, so I couldn't, do that at another school. But I don't want to belabor this. I just wanted to go ahead and turn it over to Mr. Quadricos Driscoll, who's a former, I think it's a 2016 40 under 40 winner, and he's going to lead us today on our topic on treatment access and health equity, protecting the value of copay assistance to improve patient outcomes. That's a lot. There's more than a mouthful. So I'll turn it over to the experts and let them explain it to you. So Quadricos.
Thank you, Brandon, for that kind introduction. And it's good to be back with the National Minority Quality Forum. I am Quadricos Driscoll. I'm the Vice President of Public Policy and Government Affairs for the Autoimmune Association. I'm also the Executive Director of the Let My Doctors Decide national campaign. I'm proud to be with the National Minority Equality Forum, as I mentioned again, and to moderate today's conversation. So I certainly want to thank NMQF for hosting this important yet this timely briefing and providing a platform for our speakers who will provide critical and timely updates on the federal landscape around copay assistance and opportunities to engage in this work. So in the next hour, you will be hearing from experts about the important role that copay assistance plays to help patients access and adhere to their prescribed medications and how such programs impact health equity. Our panelists will have an opportunity to discuss such topics, three primarily: patient impact of copay assistance, the federal, state, and policy landscape on efforts to protect the value of copay assistance for patients, and why action is needed to protect patients from harmful insurance loopholes that impact such programs as copay assistance. We will also have an opportunity to engage in a discussion with our panelists and take questions from our live audience at the conclusion of today's program. So before we begin our program officially, I want to thank you, the live and on-demand viewers, for joining us for today's event, and also take the time to understand how you can help to protect patient access to affordable treatments. And so on behalf of the National Minority Quality Forum, NMQF, I would also like to thank our guest speakers for taking time out of their extraordinarily busy schedules to participate in today's event and to share their perspective. Our presenters today include Rachel Klein of the AIDS Institute and Colette Kalianos of the National Hemophilia Foundation. So before we begin, I want to remind everyone, as Brandon echoed, of why we're here today. Copay assistance programs are critical resources to help patients access and adhere to their medications. Many individuals who rely on copay assistance depend on these medications to stay alive, healthy, and well. Additionally, many racial minorities and underserved communities bear disproportionate burdens of preventable illness and raising healthcare costs, many of whom look to their programs to access their medications and manage their overall health. However, we are seeing that insurers and pharmacy benefit managers, also known as PBMs, are more often refusing to count the value of copay assistance towards a patient's deductible or their out-of-pocket requirement for their plan that particular year. As you can imagine, this is a serious concern, and we know that when patients' out-of-pocket costs go up, treatment adherence goes down, leading to worse health outcomes, especially for vulnerable racial minority patient communities and underserved patient communities that already bear a disproportionate burden of preventable and chronic disease. When that happens, it can increase costs in other parts of the healthcare system. In fact, a recent study has showed that non-white patients are disproportionately affected by such insurance and PBM practices that impact the value of copay assistance, which often referred to as copay maximizers or copay accumulators. The researchers also found that non-white patients were 31% more likely to be exposed to copay accumulators than white patients, and 27% more likely to be exposed to copay maximizers. Fortunately, patient advocates, like those of us on the call today, have some successes in the past few years to protect patients from these programs. To date, 14 states and Puerto Rico have passed legislation to ban policies that prevent copay assistance from counting towards a patient's out-of-pocket responsibilities. Additionally, there is growing bipartisan support for federal efforts to require health insurers to count the value of copay assistance towards a patient's out-of-pocket cost. A federal bill to protect the value of copay assistance called the Help Copays Act currently has over 60 co-sponsors in Congress. However, there is still much more work to be done in order to protect patient access to care and improve health equity. Today, we will dig into these issues and explore the opportunities to protect vulnerable patients who rely on copay assistance. As a friendly reminder for our live audience before we begin, everyone on today's webinar is in listen mode only, but you can use the chat box feature to submit questions to the speakers throughout the program. So with that said, let's get started. First, I would like to introduce my colleague, Rachel Klein, the Deputy Executive Director of the AIDS Institute. Rachel leads the AIDS Institute's federal policy work, also coordinating advocacy efforts to advance policies that increase access to healthcare and treatment for people living with or at risk for HIV and hepatitis C. She also co-chairs the HIV Healthcare Access Working Group. In addition to her work with Congress and the administration, Rachel has worked extensively with state-based healthcare advocates. Rachel is here with us today to talk more about the patient impact of copay assistance, the landscape around the growing practice of copay accumulators, and how policymakers are taking action. Rachel, thank you for being with us today, and I'll turn it over to you.
All right, thank you so much. I'm going to go ahead and share my screen here so that I can, let's get started. Okay, you guys should now be seeing my slide, all right? Okay, I'm going to go with yes. I can't hear you. And good now afternoon to everyone, and thanks for having me here today. I'm really glad to be able to have this conversation with all of you about this really important issue. I want to start by kind of having a little bit of a conversation about what is the state of health insurance today, because health insurance really is the gateway to health care. Most people in the US now have health insurance. And the rules around health insurance and how that's structured really determine how people experience the healthcare system. And so the first thing I want to talk about is how that system has been changing over the past decade. There have been some really important changes happening in sort of how insurance is structured and who is bearing the costs of care when people seek care. Everybody knows and has been hearing lots about how premiums have been, health insurance premiums, which is the monthly amount that you pay for your health insurance, have been increasing pretty substantially over the past decade, but they're not the only costs that have been increasing. And so people are paying more to buy insurance. And then when they have insurance, they're paying more when they go to get healthcare as well. The two ways that patients end up paying when they go to get healthcare is, number one, through a deductible for a health insurance plan. Most plans today have a deductible. That's an amount that you have to pay before your insurance really kicks in and starts covering the costs of your care. And those deductible amounts have been increasing pretty substantially over the past decade and have really almost doubled just in the past 5 years or so. The median deductible for a silver plan in the individual health insurance market that you would buy in the marketplace is now at approximately $5,000 for the year. And so that's a pretty substantial amount of money. In addition to that, we are seeing health insurance plans shift more of the cost of care to people who are using healthcare. And in particular, we've seen this happen with prescription drugs. And so after you meet your annual deductible and your insurance starts kicking in, you have to pay a share of the cost of the care that you get. And for prescription drugs, you may know that your health insurance plan has a couple of different tiers. So for generic drugs, usually on the first tier, you might have a copayment that's maybe $5, $10, $15. But for brand name drugs, that copayment can be significantly higher. And what we are starting to see is plans that may have as many as 4 or 5 or more tiers of prescription drugs, and specialty drugs, which are the ones that many people living with a very serious and complex chronic illness use, can be on the highest tier. And they are more likely to have now a coinsurance, which is a percentage of the list cost of the drug. So people are being asked to pay more and more of the cost of the care that they're getting, and this is particularly impacting people with chronic illness. Cost is not the only way that insurers and PBMs control access to care, and particularly to high-cost prescription drugs. They do it through utilization management. So they are able to determine what the formularies are, which drugs are being covered. They may control for specialty medications, which pharmacy you have to go to in order to get your drugs. They use prior authorization and step therapy in order to make sure to steer people to the specialty drugs that they would prefer that you use instead of others. Oops. I need to, okay, hit the wrong button there. So as I said, we've been seeing these deductibles increase substantially. And you can see here, this is just a little evidence of these silver plans, where now you can see that these deductibles are really clustering in the $4,000 to $6,000 range and the $6,000 to $7,500 range. And that's an awful lot of money for people who have chronic illness in particular. When your healthcare dollars are so scarce and you need so much care, it is becoming harder and harder for people to afford the healthcare that they need. And this is just some data about the use of specialty tiers and more insurance plans shifting to co-insurance, particularly for those high-cost medications. So I want to just flag that, as these costs have been going up, our pocketbooks haven't been extending in order to cover these additional costs. And looking at some of the data, what we can see is that 69% of people in single-person households and 56% of people in multi-person households, families, don't have $9,000 in liquid assets. And $9,000 is the max out-of-pocket cost for health insurance these days, or that you'd be asked to pay for your health care. And 45% of single-person households and 30% of multi-person households don't have $2,000 in liquid assets. So people are really struggling to meet the costs of their healthcare. And this is particularly true for people of color, for people with low incomes, and for people who have poor health. And what we're seeing is borne out in the data as well. 23 million adults now have what is considered significant medical debt. 26% of them owe more than $5,000, And again, medical debt is really hitting people, people of color, people with lower incomes, people with poorer health. And we should note that medical debt is inextricably linked to social determinants of health. When you're holding medical debt, you are at an increased risk of food insecurity, of housing insecurity, and just generally not being able to meet your basic needs. And so this is a really serious concern. So what do people do when they have serious and chronic illness and they need to get a specialty medication? They tend to turn to copay assistance that's offered by manufacturers that helps fill that gap between what the cost is of their treatment and what they can afford to pay. I want to note that 97% of copay assistance is available for a brand name drug that does not have a generic alternative. So there's been some concern expressed about copay assistance that it might be steering people to higher cost drugs instead of lower cost drugs. But the reality that we see is that we're really talking about prescription drugs that are treatments for people with serious and chronic illness that are relatively newer on the market. They're more complex drugs, often they're biologics. And so they really do not have a less expensive alternative. These are prescription drugs that people are prescribed for treatment after they have gone through all of the other utilization management that we've talked about, where insurers are really sort of saying, here are the ones we prefer you to use. At that point, the person is saying, okay, here's the drug that you've told me that I should be using, that my doctor has told me I should be using. How am I going to afford to pay for it? Copay assistance is really not a coupon. It is financial aid that helps people now pay for the treatments that they've been prescribed by their doctors. I want to flag that, insurance, employer insurance has some additional flexibilities with the benefit package that individual and small group plans don't have. And we're starting to see more gaming of the system in terms of how insurers are controlling access to higher cost treatments. And I know my colleague Colette is going to talk a lot more about that. But I did just want to sort of flag that as we're talking about the different ways that insurance is being structured, that's shifting more and more of the burden of cost to the enrollee, and is really forcing people to seek assistance to meet those costs and make sure they can get their treatment. Insurers, in the sort of noticing that people have been using and relying on copay assistance, have put into practice over the past few years some new policies that we're going to talk about today. These copay accumulator adjustment policies that Quadricos mentioned, and copay maximizers. And really what has happened is that even as patients have turned more and more to copay assistance as a way to afford their treatments, the insurers have said, okay, well, we see that you are using this copay assistance to purchase your treatment. We are going to stop counting the amount of money that you're using in this financial aid toward your deductible and out-of-pocket maximum. And what happens when they do that is that people are not able to ever get to their deductibles or that out-of-pocket limit. My colleague Colette is going to talk a little bit more about a twist on this that's called a copay maximizer, and talk about that in more detail. Essentially, with both of these different things, what you're seeing is that people are using copay assistance, but then when they hit their deductible and out-of-pocket costs, out-of-pocket maximum, it's not being counted. So the effect on patients is that, and you can see from this example here, if you've got a patient enrolled in a plan with $1,000 deductible, they have copay assistance to pay for a $100 prescription refill. That's their out-of-pocket cost. If you do not have a copay accumulator or maximizer in your program, when you use your copay assistance, you're paying the insurance company and the PBM, you're out of your copayment, and that amount gets deducted so that your insurer says, okay, you've now paid $100 toward your $1,000 deductible. Now you owe $900. And then you sort of continue doing that until you hit that $1,000. When you have a copay accumulator, they just don't count it. So even though you may have paid your $100, you still owe $1,000 until you hit your deductible. And this has a really significant impact on people because when their copay assistance runs out at some point during the year, they go to get their prescription filled or to seek other healthcare treatment. And they find out that none of those costs have been paid down. And instead of hitting an out of pocket, instead of their insurance kicking in to cover more costs, or instead of hitting that out of pocket max where the insurer has to cover all of the costs, they are stuck without, paying those bills over and over again, or being asked to pay those bills over and over again. And we know that this infects people of color at a higher rate and have a greater burden because people of color are much more likely to have lower savings. They are more likely to have medical debt. They are more likely to be living with chronic illness. And I can give you an example from the HIV world where we know that the greatest burden from HIV is squarely in people with people of color. Only 30% of people living with HIV and 25% of new cases of HIV each year are people who are white. And the remaining 70% of people living with HIV and 75% of new cases are largely with people who are Black and brown. And that disparity continues. And so we know this is a significantly greater burden among people of color. Let me just get to my next slide. I want to talk a little bit more about the prevalence of these plans. We have done studies each year at the AIDS Institute looking at the prevalence of these plans. And what you can see here is that in 2022, 35 states have at least one plan with a copay accumulator adjustment policy. In 8 states, every plan has a copay accumulator adjustment policy. In 30 states, half or more plans have these policies. And in just 3 states plus DC, the insurers have voluntarily chosen not to have these policies. And this was at the start of 2022, 12 states plus Puerto Rico have passed laws prohibiting this policy. We now have 14 states with those laws and 2 more where those laws have been enacted and are awaiting governor's signature. So going into 2023, there should be 16 states plus Puerto Rico where this policy is simply not allowed. We have asked the federal government to take a look at this, and we really urged them to make sure that copay assistance counts for patients. And in 2019, HHS said, yes, we agree with you. And they put in the annual notice of benefit and payment parameters a rule that said that insurers and PBMs have to count any co-payments made by or on behalf of an enrollee toward their annual deductible and out-of-pocket max. Unfortunately, a few months later, they reversed course and initially said, hey, we're just going to take another look at this. We have some concerns. The IRS in particular had some concern, particularly related to people who have high deductible health plans with a health savings account, which, by the way, is a very, very small fraction of people living with chronic illness. And so they went back, they looked at it, and then sure enough, they decided in the 2021 notice of benefit and payment parameters that they were going to allow insurers and PBMs to continue using copay accumulator adjustment policies with really virtually no limits unless a state enacted a law like we just talked about. 14 states now have done. So we continue to urge HHS to take a regulatory action and to protect patients by limiting or prohibiting this practice. Since they have not yet done that, we have been working with members of Congress to introduce legislation that would prohibit this practice. And earlier this year, the Help Copays Act, which is the Help Insure Lower Patient Copays Act, which is HR 5801, and Quadricos mentioned this at the outset of the call, this bill was introduced in a bipartisan manner by Representative McEachin from Virginia and Representative Davis from Illinois. There are 61 co-sponsors, last I looked, for this legislation, and they are bipartisan on both sides of the aisle. And we are actively seeking Senate champions so that we can get a similar bill introduced into the Senate. This bill has two key provisions, and I'm going to talk about the first one, which basically would clarify that if a payment is made by or on behalf of a patient for a healthcare service, and particularly prescription drug, that the insurer and PBMs have to count that toward the deductible and out-of-pocket maximum, just like all of these states have said for the programs within their jurisdiction. And so this would really be an important change because it would address the problem both for individual insurance as well as for employer insurance, and it would make sure that people who are relying on copay assistance in order to fill that cost gap are able to continue using it and getting the full benefit of that assistance. There's a second provision of that bill that addresses employer plans, and I know that my colleague Colette is going to talk more about that provision, so I'm going to pause here and turn it back over to Quadricos.
Thank you, Rachel, so much for that wonderful presentation, and particularly, I think, highlighting medical debt. We know that because of these programs, certainly it does have a disproportionate impact on vulnerable patient communities. So thank you so very much for that. Next up, we will hear from my colleague, Colette Kalianos, the Vice President of Payer Relations with the National Hemophilia Foundation. As the Vice President of Payer Relations for NHF, Colette is responsible for the development and execution of hemophilia's payer education strategies and programs. Colette and her colleagues at NHF are also critical steering committee members in the All Copays Count Coalition, which is a coalition, an alliance comprised of members serving the interests of beneficiaries with chronic and serious health conditions that rely upon copay assistance to access medically necessary treatments. Colette and the National Hemophilia Foundation have conducted invaluable research on the impacts of copay accumulators and adjustment programs, and research that is the backbone of much of the policy and advocacy work that we do. Colette, take it away.
Thank you very much, Quadricos. First of all, appreciate you, and I appreciate Rachel. And I wanted to just clarify, when Rachel talked about the critically important work they do, they put out that report every year looking at the plans that have copay accumulators, or the states that have plans with copay accumulators, or those that don't. And she talked about at this time, 14 states plus Puerto Rico that have banned copay accumulators. It's important to note that when a state bans copay accumulators, in the case of those 14 states in Puerto Rico, that only applies to marketplace plans and small group plans. There can still be copay accumulators in those states on self-funded employer plans. And given that 64% of all employer-sponsored plans are actually self-funded, there are still an awful lot of people that are potentially exposed to these all across the country, which is why we are working so hard to also get federal legislation passed to address this. So I'm going to now see what, okay. I'm going to just do a real quick start here. Why are these things happening? Well, payers, and we're going to, a payer, when I say payer, I mean a health plan like United, Aetna, Anthem, etc. Or it's an employer who's self-funded, who's paying the claims for their members. Now they use an insurance company to act as their third-party administrator, but it's still ultimately the employer who's paying it. So when I say payer, I mean anybody. This is the top strategic priorities for payers, as reported in Mercer National Survey of Employer-Sponsored Plans. Since then, there's been multiple other surveys done. It remains the top, which is monitoring and managing high-cost claimants. And most chronic health conditions that are like hemophilia, they are expensive to manage. And so understand from their vantage point why they're focused on these, that I understand. But patients, you know, they don't ask for the conditions that they get. And plans, when they focus on these, they're trying everything they can. They're trying to throw one size fits all strategies to try to stop the flow of money going out. Again, I understand, but some of the strategies the top strategies today include patient cost shifting. More and more costs are being shifted to patients. And then these copay accumulators and maximizers and other utilization management strategies. You heard a lot of information from my colleague Rachel about copay accumulators, so I don't have to get into those, but the cost shifting part, and she also gave a snapshot of where we are in our country. But 85% of all health plans have a deductible. If you have a deductible on your plan, you must pay the deductible in its entirety before the plan will pay the first penny. And 51% of US workers are on a high deductible health plan, which means at least $1,400 for an individual, $2,800 for a family. But that deductible can go all the way up to $8,700 and double that for a family. You heard Rachel say that the average deductible today is $5,000. So that's where the problem lies. You have to pay the entire deductible before the plan kicks in the first penny. People will say, well, they should have chose a different plan. Many employers only offer high deductible health plans. But even if there is a choice of plan, if they're purchasing on the marketplace, for example, then somebody asked the question in the Q&A about what's a silver plan. There's bronze, silver, gold, and I'm going to say platinum. I can't even remember the last one, I'm sorry. But silver sits in the middle. However, when folks are already cash strapped, which let's face it, the majority of Americans are, and they're choosing a plan, they're going to choose the plan that actually has the least burden on their out-of-pocket. So they're going to pick lower cost premiums. The lower the cost premium, the higher the out-of-pocket. Americans don't understand basic healthcare terms, so having them understand this as they're choosing is a difficult thing to begin with. So Rachel talked about copay accumulator policies, and those are ACA compliant because what it simply says is you can use assistance, but you yourself have to pay your own out-of-pocket. Now imagine that these aren't just targeting manufacturer assistance. These are targeting any assistance. In fact, many plans say you can't use any no assistance counts to your responsibility, not manufacturer assistance, not third-party nonprofit assistance. And so imagine now you're in the store shopping, you run short, you don't have enough to pay, you're $11.10 short, and I am behind you and I say, you know, let me cover that for you. And they're, no, I really want to do it, please. You can pay it forward someday. So I pay you $11.10. You go about your business. The store didn't get a discount. The store actually got the money. It's just they got help from someone else. You go to walk out the store and somebody stops you and says, nope, you can't leave. You owe us $11.10. No, the other nice lady behind me paid. I call myself nice, sorry. And so the guy in the line or standing at the door says, it doesn't matter, you have to pay it yourself. That's what's happening here. So that's the accumulator and also the maximizer. They're saying you have to pay your own out of pocket. However, with an accumulator, if you say at the beginning of the year, I'm one of the fortunate Americans, I've saved for this, I have my own money, and let's say your deductible is $5,000, you pay your own deductible the very first month when you need your meds. The rest of the year, your insurance company is going to cover your covered costs at 100%. But on a copay maximizer, it's not ACA compliant. So you won't see the maximizers on marketplace plans or small group plans. You'll only see them on ERISA plans or large group plans because they're claiming that specialty medications are not an essential health benefit. That's how this works. And we're calling it a loophole. It's not, to me, there's no loophole. It's very clear, black and white. There's 10 essential health benefits in our country, and prescription drugs are one of them. However, they're claiming specialty medications aren't specifically called out. Well, neither is asthma medicine or psoriasis medicine. I mean, they don't call out any medicine. They say prescription drugs. So they're making, they're choosing to interpret that as this is not something that we have to cover, and therefore it's a non-essential health benefit. They remove those drugs outside the plan. And they also say you can use assistance. In fact, they encourage you to use assistance. And if you don't, you get penalized. You'll see what I'm talking about here. But I just want to point out, this is kind of ironic. Express Scripts, one of the companies who started copay accumulators, asserts that manufacturer copay assistance programs are the cause of escalating drug prices. I'm not here to debate their argument, but what I am here to say is I don't agree that that's the only problem. I agree that's some of the problem. Drug prices should come down. But there's other people who make money in this equation that you can't see because it's opaque, that are costing the health plans a lot of money as well. The middlemen is who I'm talking about. So they say that the cause of drug prices, hence the reason they support and actually started copay accumulator programs. You'll see at the bottom what I highlighted. These programs ultimately drive up the overall cost of prescription drugs. It's important to know that because Express Scripts then forms a new company, they call it Save on SP, and that company actually promotes the use of manufacturer assistance programs. That's what a copay maximizer is. They say that they leverage provisions of the ACA to maximize copay assistance for those medications that, that people require. The program is designed to help members save money on their specialty medications by taking advantage of the funds available through drug manufacturers. Hang on, you said it's bad. It's driving drug prices. Why are you now going to penalize a patient who doesn't choose to enroll in that program? So by asserting specialty medications are non-essential, they are then saying to those patients who say, I want to pay it myself, because they call these non-essential, they move it outside the plan. And if you said to them, I don't want to enroll in manufacturer assistance, I would choose to pay it myself, they'll say, well, because it's considered a non-essential health benefit, you should know that you'll pay 30 to 70% of the cost of those drugs every single month with no out-of-pocket max because they fall outside of the covered essential health benefits. If you enroll in the assistance program, then you can get your drug at no cost to yourself. So they say specialty medications are not one of the 10 essential health benefits. I cannot agree with that. It does not, I don't even know how they're getting away with it, frankly. Prescription drugs are one of the 10 essential health benefits. And then they say for members who qualify and enroll in Save on SP, to be clear, because I hear people say this all the time, well, you have to qualify. The only qualification is you're on a specialty medication that they have identified, which is for usually 13 or 14 of the top cost therapeutic class. To qualify simply means you're on one of those drugs. And so here's a benefit plan for one particular college that Save on SP. This was what the patient received. Participants eligible to enroll in the program if they take these specialty medications, covering conditions such as Hep C, muscular sclerosis, psoriasis, inflammatory bowel disease, rheumatoid arthritis, and others. Others being cancer, hemophilia, cystic fibrosis, spina bifida, muscular dystrophy, lupus. The list goes on. And you could really tell me that these are non-essential. And furthermore, as you see at the bottom here, the copay that you receive from the manufacturer won't count to your out-of-pocket or your deductible. And if you said you wanted to pay it, as I told you, that's where you would find out that sorry, it's a non-essential health benefit, and therefore you have no out-of-pocket limit on those particular drugs. Same with CVS. They promote the need for accumulators for all the same reasons. However, they spun off another company called Prudent RX, and they encourage patients to enroll in the program. And I know I don't have enough time to go through all these. I'm sure the slides will be shared for those who wish to see them. But bottom line is, they're saying that Prudent RX will help members get copay assistance from drug manufacturers to reduce their cost share. So they admit that members need this help here. It will not count to their deductible though. And so any cost share payments that are made for these medications, whether it's by the manufacturer assistance or by the patient, does not count to their max out of pocket. That's the problem. And there's other programs and games that are being played where they're just simply saying, here's another deal. Let's just simply not cover any specialty medications and try to get patients on the free product. And the issue here is they're throwing mud at the wall, but only the most vulnerable people are getting hurt. Because if you don't have the money, how are you going to pay those kind of dollars? Is simply not possible. The bottom line is, why are they doing this? They're doing this because this slide, which was presented by Cleveland Clinic at the PBMI conference to other PBMs and employers. Why would you want to make sure you get to take advantage of all the manufacturer copay assistance? Is because look how much money we saved, almost $9 million allowing that copay assistance to come in. But on the other hand, they're saying copay assistance is bad. Patients are getting caught in the middle of this game. And you'll see here, and the only point I wanted to point out on this slide is the annual savings, where they show this as being a savings to the plan. It is being pocketed by PBMs and health plans, and patients are getting hurt. This is the kind of hurt we're seeing. Patients, somebody in our community, this is the benefit notice they received. Hard to read those, but one says we'll no longer cover specialty drugs beginning January 1, 2022. The last bullet on the left-hand side, top section says, beginning January 1, 2022, to save further healthcare dollars, we will no longer provide medical coverage for patients who have spina bifida, hemophilia, or cystic fibrosis. Now, what about discriminatory can you say? I mean, we're not supposed to allow for discrimination, and yet that's exactly what these practices are when they're only targeting certain therapeutic classes. These are the kind of companies that have popped up doing these kind of programs. And I just wanted to show you just how proliferated this is. And I'm happy to answer any questions that you may have. And thank you for your time.
You know, Colette, I think that it was extraordinarily important to highlight the fact that copay maximizers and accumulators are operating because they're not deemed as essential health benefits, right?
On the maximizer, it's a non-essential health benefit. On an accumulator, they admit, like the marketplace plan, CMS, HHS would never allow a marketplace plan to say the specialty drugs are not an essential health benefit. They're doing it because, as you heard my colleague Rachel say, they do have a lot more flexibility as self-funded companies. They don't have to cover essential health benefits. But if they do cover that category, and prescription drug is a category, the rules say then cost sharing limits apply. But they're saying specialty drugs aren't one of those 10, so that's how we can get around this. And that's really the tragedy here.
Right, absolutely, which is of course driving up costs. So with the time we have remaining, let us get into some questions. And at present, I don't necessarily see any in the chat. So I do have one question. What perhaps is the biggest barrier to patient access and treatment?
Well, for me, I'll just say the biggest barrier is you can't push a patient any further. The cost shifting has gone too far. There's 168 publications and abstracts that show kind of the corrosiveness of high deductible health plans to people with chronic health conditions, because they simply can't pay these kind of out-of-pocket costs. My daughter has a high deductible health plan. She pays $1,000 some odd a month for her premium for her and her 2 boys, but she has a $7,000 deductible. So she pays for insurance she could never use, because she could never pay $7,000 to be able to get the plan to start paying its first penny. That's really what's happening, and why, you know, people who have less socioeconomic means, they could work hard 2-3 jobs to have enough to get insurance, and then they can't use it. It's not right. And these other companies are profiting off the backs of these hardworking, vulnerable Americans.
Thanks, Colette. Rachel, any?
Yeah, I mean, I think Colette really covered it. Really, the issue is cost, right? Healthcare is too expensive for people to be able to afford on their own. That's why we buy insurance, because that's supposed to make it more affordable. But when insurance is shifting those costs to patients, especially those who really need healthcare, then, you know, we're really seeing that there's a disproportionate burden on people with chronic illness and people who have high healthcare needs. There's extensive data that shows that with a copayment of $250, people will walk away from the pharmacy counter, even for a prescription drug that they desperately need, something that is life-saving. And I think what we're encountering now with higher and higher deductibles and out-of-pocket costs is that people are being faced with, even when they have bought insurance, they're being faced with out-of-pocket costs that go way beyond $250. They may be asked to fill a prescription that costs hundreds of dollars per fill, or even thousands. And that is really simply beyond the ability of most people to pay. Americans just don't have that much in the bank at any one time, much less every single year.
Yep. And I would just say our patients, the drugs, and we're not the only, but our patients, the drugs, the average cost a year is over $300,000. So every single year in January, if you have a blood disorder and you require, these medications, you would have to pay your full deductible the very first of the year. And there's just simply no way. And I had additional slides I stopped at because I know I had hit my time, but the question was asked in the Q&A about whether or not, or the HR 5801 addressed accumulators, but what did it do for maximizers? So there's two parts of that bill. One, is obvious. It talks specifically about accumulators. The other one, it talks about the EHB loophole. So what I'm saying is, I told you, and remember, maximizers can only be on self-funded ERISA plans, which is the majority of all commercially insured, and large group plans. And large being anything over 50 people on a company plan. In most states is large, some states it's 100. But so to be clear, that's the majority of all commercially insured, okay? So if there is a maximizer on the program, that is meaning they're saying it's a non-essential health benefit, these drugs. And so what the EHB loophole would close is saying, we know you don't have to cover EHBs as a self-funded plan, but if you do, cost sharing limits apply. And if you're covering prescription drugs, any prescription drugs, then you need to say that all prescription drugs are essential health benefit and you have to have cost sharing limits. And that's what's being circumvented. Hence, we call it the loophole. But again, I don't want to agree that it's a loophole because that would suggest that there is that ability for them to say this because it was somehow missed in the ACA. No, it says prescription drugs and these are prescription drugs.
Thank you, Colette, and thank you for recognizing one of the attendees' questions, which was part of the Help Copays Act, is it clarifies the definition of cost sharing within the ACA, but how does it address copay accumulators and what does the act intend to do for maximizers? So just to add on to that question, of both Rachel and Colette, how can advocates really engage the All Copays Count Coalition to support the advocacy work and address and help move forward the Help Copays Act?
Well, I would say, if you're interested, if you're not already, one of the close to 100 member organizations, and it's, to be clear, it's only patient and provider organizations, that we don't allow manufacturers to participate in that program in our coalition. That you just have to let us know, send a message. I think you can go on our new website, the allcopayscount.org, and there's a lot of resources on our website, including an interactive map of all the states that have current legislation and those states that are pending. And you can ask to be added to the coalition that way, or you could, again, send it to us. But I think I do want, real quick, somebody also said in this question here, what can patients do to mitigate the cost of their medicine when they max out their copay assistance? Well, in the case of many of our patients, there's nothing they can do. They're simply just not going to be able to get their meds. And what employers don't understand, because they're not thinking all the way through, if our patients don't get their meds at the pharmacy counter, they're going to have to go to the ER because they can't avoid their clotting factor infusions. And every health plan understands that the emergency room or the hospital is the highest cost of care setting to be paying for these claims, and they would have to pay them on the medical side. So it's a short-sighted decision, and it's only causing either them to get more costs as health plans or patients to have worsening health outcomes.
Thanks, Colette. Rachel.
Yeah, I do want to echo what Colette said about the All Copays Count Coalition. We have been working together on this for 4 years now, 5 years. And Our coalition has only grown over the past few years. We can see that there's more and more interest amongst patient organizations on this issue, and we are thrilled to have more help. I think it's really important that HHS, that Congress, and state legislators see the breadth of different kinds of patients, patients with different conditions who are experiencing this issue, because the more of us who speak up, the more powerful we're going to be, and the more likely we are to get the attention of the legislators and the regulators who need to address this issue. And then in terms of, what can patients do, I want to just sort of note that, the idea of a deductible and who is going to meet that deductible, most people don't, right? Most people who have health insurance never meet their deductible. They never hit their out-of-pocket maximum. My kid who has a chronic illness meets the out-of-pocket max on their plan every single year. And so when health insurance, when the rules of the Affordable Care Act were sort of set out, they were done so with the idea that most people don't have these high costs. And for the vast majority of people, it doesn't really matter. I wouldn't say it doesn't matter, but it's less important if that deductible is $2,000 or $5,000 or $9,000, because most people don't even have $2,000 in out-of-pocket costs during the year. But now that we are up at $9,000 per year, as you could see from the data that I presented, the vast majority of people do not have that in their bank account, and they simply can't afford those costs. Deductibles were designed with the idea of things like an emergency room visit or a catastrophic accident that you would have extended medical bills for. And most of the time that would be through a hospital or a provider where you can negotiate those costs and you can set up a payment plan so that you can pay them over time. When you're talking about prescription drugs, you must pay the full amount at the time of the refill, or you walk away without your drugs. There is no payment plan for prescription drugs. So the way that this has evolved is really untenable for people with serious and complex chronic illness.
Thanks, Rachel. And listen, we have about 3 more minutes left according to my clock. We've talked a lot about federal efforts around this important topic. In the 3 minutes we have left, let's discuss what's going on in the states. And again, through the All Copays Count Coalition, how people can get involved. Rachel, I'll start with you.
So there's been a lot of work at the state level on this. And, just in the past 3 years, we have seen, 0 states going from 0 states that have enacted legislation to now 16 states that have enacted legislation. And they are literally all over the map. We have states in the West, in the Northeast, in the South, of, conservative states, more liberal states. These are just legislators who have worked, by and large, because they've been approached by patient advocates, to say we need to protect the people living in our state, and we're going to do what we can do, which is pass this law that says that copayments, regardless of their source, that are made by or on behalf of a patient have to be applied to these limits, the deductible and out-of-pocket max. But states can only protect, as Colette mentioned, and as we talked about a couple of times before, they can only protect some of their residents, the folks who have small group plans or individual plans. And that means that we need federal action to really close the loop here and make sure that folks are protected. Now, we hope that there will be even more states that will take action in the coming year, because I think it definitely helps. And it helps build momentum and show how important this is for so many people. Colette, I don't know, you have things to add there.
Yeah, and Colette, you'll also address the last question in the Q&A as well.
Yeah, so somebody asked in the Q&A, which I think it's a great question. So what about in the case where they excluded hemophilia, fibrosis, and spina bifida on the medical benefit? What if they went to the ER and it was a hemophilia related? They wouldn't have coverage. That's obviously a huge discriminatory issue. But then the crazy thing is, if they wanted to go on the marketplace now, because clearly their employer coverage is not adequate, it doesn't cover the condition they have, they could get on the marketplace, but they would be penalized in that they could never get subsidies on the marketplace because they're offered insurance through their employer. And, you know, in some states, if it's not open enrollment, we would have to fight on their behalf to even have an exception to get on the marketplace. But I'm making the assumption now it's either we got that exception or it's open enrollment. If their employer offers them insurance, they would not qualify for subsidies. How can you say that that's adequate insurance? I mean, these are the issues and the challenges we face and why this demands legislative action.
Absolutely. Listen, thank you both so much. And on behalf of the National Minority Quality Forum, I want to thank you again for our esteemed guests, Rachel and Colette, and all who have attended for today's events. We certainly hope that you all will find ways to remain engaged on this important patient issue going forward. We have many opportunities before us to protect patient communities, all patient communities, most especially those vulnerable. On a federal level, the Help Copays Act would ensure copay assistance count towards patients' cost-sharing requirements and strengthen the protections in the Affordable Care Act for those living with pre-existing conditions. The All Copays Count Coalition is a collaborative effort of patient and provider groups who are dedicated to protecting patients from harmful copay accumulators. More information on the coalition can be found at allcopayscount.org. Again, as we continue to discuss the challenges of protecting patients from harmful insurance practices, it is important to note that this is a conversation has highly been recognized and highlighted for the urgent need for more research and dedicated effort on the impact of costs and barriers to care on health equity. So we hope that you found today's program valuable, and we encourage you to remain engaged on this issue as it continues to evolve as we address solutions for all patients. This concludes today's program. Thank you, and do take good care.
Thank you.
Thank you.